Hello, my name is Gene Bleecker. I'm a professor of pulmonary medicine, and I also direct the Human Genomics and Personalized Medicine Center at Wake Forest University in North Carolina. I also serve as chair of the Asthma Committee for the World Allergy Organization. I've been asked to talk to you a little bit about severe asthma. What is severe asthma and why is it important? Officially, severe asthma is defined by the ATS-ERS task force as a disease which is poorly controlled despite the use of high-dose inhaled corticosteroids or oral steroids and other controllers, or patients that lose control when corticosteroid dose is reduced. Is this frequent? In practices such as ours at a university, it probably is as much as 20% of the population. In other practices, perhaps 10%. But poorly controlled asthmatics who have frequent exacerbation are a cause of immense healthcare utilization. What's new in our understanding of severe asthma is a greater understanding of phenotypes, and these are complex phenotypes, and the endotypes that form these phenotypes. In an analysis that we've published from the NHLBI Severe Asthma Network, a cluster analysis, we've shown there are three groups of severe asthmatics. One, severe asthmatics who have started asthma early in life, have a Th2 phenotype with persistent eosinophilia and high reversibility. There's also a group of older severe asthmatics, more often women, often obese, who have an onset of disease not at age 10, but at age 40, who have also persistent eosinophilia, often with neutrophilia, and relatively preserved lung function, but frequent exacerbations, often more than 3 a year. And finally, there's a group with severe losses of lung function, very much like you would see in COPD, except these are not smokers, who have limited reversibility, and examination of their induced sputum shows both eosinophilia and neutrophilia. Why are these endotypes important? Because we're developing a whole group of new therapies for severe asthma. These include perhaps drug repurposing, where we're re-looking at the use of the best use of corticosteroids and other bronchodilators, including long-acting anticholinergics, as well as new biologic drugs which target specific endotypes in these populations. We will soon add to anti-IgE therapy 2 new anti-IL-5s that are now approved in most countries in the world, and under development are drugs that also affect the IL-4, IL-13 pathway. These drugs, especially the anti-IL-5s, are quite effective in reducing exacerbations and improving asthma control. But their use really depends on understanding predictive biomarkers, and really we need to apply precise or personalized medicine because of the high cost of these therapies. While this is a new era in the treatment of severe asthma, it also means we have to understand the endotypes and phenotypes in this disease even better.